So our next talk is from Dr. Lawrence Cheskin, who is Associate Professor of Health Behavior and Society at the Johns Hopkins Bloomberg School of Public Health. He's dedicated his career to research, education, and program building in the service of combating obesity. He directs the Johns Hopkins Weight Management Center. Please join me in welcoming him.
Thank you. So I'm going to be talking about obesity, and of course, exercise and obesity are tightly linked, although you will always hear some controversy as to what the nature of the relationship is, and is it bidirectional. So I hope to be able to give you some clarity, as well as talk about how we can help motivate patients and family and friends to address whatever problems they may have in this area using obesity. First, I think it's very interesting that there's really very little record of historically how much exercise people got. We think we know, but there's very little data. There is some data from the United Kingdom, and it's also indirect, but we know that energy intake in England declined by about 500 calories a day between 1970 and 1990. But BMI went up by 1 kilogram per meter squared in that same time frame. So the conclusion, logically, is that energy, physical activity must have decreased by more than 500 calories per day. There's no data, but logically that must have occurred for BMI to have gone up while energy intake went down. In the United States, there's an inverse relationship between what people self-report as their level of physical activity and their BMI. The higher the BMI, the lower the self-reported physical activity. And this is true across the demographic spectrum: men, women, blacks, whites, Latinos, etc. And it's confirmed by doubly labeled water studies looking at physical activity and intake, and 2 out of 3 longitudinal studies that I was able to find that looked at the correlation over time of the level of physical activity and your BMI. So suggestive that energy intake is a risk factor for obesity when it is low. And again, just logically, decreasing physical activity should lead to weight gain unless your energy intake goes down by the same amount. And I don't know if you have this personal experience, but when we're less physically active, you get sick, you're lying around at home or in bed, do you eat any less? Not usually. So you can see that lowering physical activity very often will not automatically lead to a compensatory change in how much we eat to decrease it. The opposite effect, if you increase physical activity, that should cause weight loss unless you eat more and compensate for that additional physical activity. And there's this concept of degree of compensation, and it's usually talked about when we talk about food. So you drink Diet Coke instead of regular Coke, you should lose a lot of weight, except that most people don't, because they wind up eating the 3rd slice of pizza because they've been so virtuous by having the Diet Coke. So you've essentially compensated for that change. And in a similar way, you can compensate for good changes in physical activity level. I went to the gym. Every gym I've ever seen has a snack bar in it. The exercise, A, may make you hungry, and B, you're virtuous. You deserve the snack bar after you've worked out. So this is also a concept that can be applied to exercise. How much you compensate for it will influence what the theoretical impact will be, for instance, of being more physically active. Physical activity also has an effect not just on energy intake, but on fat stores. Carbohydrate and protein stores in the body are very tightly regulated and limited. You can't just double your protein stores or double your carbohydrate stores. You've got a limited capacity for that. So any changes in physical activity tend to be reflected more in fat stores rather than these protein and carbohydrate stores. So I hope I've convinced you, at least logically, that exercise could have some influence, but a variable influence on body weight. What are we doing with that information? Well, less than a third of overweight patients will report, if you ask them, that their care provider has said anything about physical activity in terms of advice. And of those individuals, even when you get advice, your doctor says, yeah, exercise more, that could help with your weight problem. Fewer than 10% of those people given that general advice will actually be given substantive help in creating a specific plan for being more physically active. So we certainly can do better there, and I'll give you some examples of specific plans. How physically active we are, other speakers may have touched on this already, but more than half of adults in the U.S. don't engage in the recommended amount of physical activity. A quarter of adults do essentially no extra physical activity beyond activities of daily living. And we've estimated through epidemiologic studies about 300 to 400,000 preventable deaths each year in the U.S. are attributable to physical inactivity and sedentariness. What determines the level of physical activity between individual patients are a number of factors. Age is certainly one, and in the U.S. physical activity tends to decline in both men and women as we get older. Gender is a factor. In the U.S., adult men and women approximately equal levels of physical activity, not so in other countries. In Canada and the UK, men 1.5 to 3 times the level of exercise, physical activity, and even in the US, boys tend to be more physically active than girls. Body composition and BMI, the physical activity level of the average obese person is lower than the physical activity level of a lean person, but because when one is obese, the energy cost of being physically active is higher, way more, every step uses more energy. The total calories burned in physical activity, although the level or the steps taken may on average be lower in the obese, the level of calories expended is similar in obese versus lean people. Genetics does show an impact on the amount of physical activity we tend to get. There have been studies suggesting, family studies, twin studies, something in the 30 to 60% heritability range. So it's not purely what we choose to do in terms of amount of physical activity. Socioeconomic status, education, for instance, college grads in the U.S. are 2 to 3 times more likely to be active in leisure time physical activity than non-college grads. And there's even seasonal variability. Canada, more dramatically than in the United States because of the generally colder climate there. The time spent in Canada in physical activity during the summer is twice the time spent in the winter. So Canadians will tend to gain weight in the winter as a result. How much exercise is needed for weight control is actually, I don't like to advertise this because the numbers are rather discouraging. Even though most guidelines talk about, modest goals, 20 to 30 minutes of moderate intensity physical activity, most, preferably all days of the week. Institute of Medicine guidelines are finding that it may take just about 60 minutes a day of moderate intensity exercise just to help you maintain your weight, and 90 or more minutes a day to actually lose some weight for the average adult. Reducing sedentary time can do the equivalent of increasing physical activity time, but still, this is a lot of time in what is often very busy lives that people are facing. Correlations, at least 2 studies, one of which I was involved in early in my career, found that kids who watch a lot of TV, and now be any kind of screen time, computers and little screens, are more likely to be obese than kids who don't spend a lot of time in that kind of activity, if you want to use that term for it. And important to figure in that lifestyle activities, taking the stairs, parking farther away, that sort of thing, can add up to a good deal of extra physical activity. And for obese individuals in particular, that may be something they're more comfortable with starting with than you're going to go to the gym and work out for an hour. Keeping in mind the difference between physical activity and exercise. And again, you don't need to push it as exercise. Physical activity is any sort of bodily movement, contracting skeletal muscles that burns calories, whereas exercise is more of the planned physical activity that is structured and repetitive, going to the gym twice a week or something. Measuring physical activity level is not often an exact science unless you're going to do doubly labeled water studies, but a very common measure is physical activity level, or PAL, which is your total daily energy expenditure divided by your resting metabolic rate. So if you sat in a chair the entire day, how many times more than that do you spend in energy in a day? And for a sedentary adult, it's 40 to 50% more than sitting in a chair all day is the calories spent in total energy expenditure. An extreme athlete may expend 3 or 4 times as much energy as their resting metabolic rate in a day. And as I mentioned, there are very precise tests, doubly labeled water, very expensive isotopes that can be used to accurately gauge physical activity level. And it looks back for 14 days if you do a 14-day test. But you can also get somewhat less accurate measures with things like accelerometers, Fitbits, heart rate recording even, and just writing down your physical activity and trying to calculate from there. We do, I think, have to broaden our concept and our discussions with people that we're helping the range of physical activity. And it is from activities of daily living to non-productive activities like fidgeting. You know, if I gave this talk pacing back and forth, I'd be burning more calories than if I lean on the podium and, you know, try to stay awake. A related concept is called NEAT, which you've probably all heard of, non-exercise activity thermogenesis. I'm not sure if that includes fidgeting. It probably does. And there's a very large variability in this, and some studies have suggested that this is an important predictor of BMI. And there have been studies where you lock somebody in a room without anything to be physically active with, no exercise equipment, and there's radar sensors in the room, and you can measure the amount of non-exercise activity thermogenesis, and the range is something like 200 to 1,000 calories a day, 5 times range of people, the average person, locked in a room. How much do they move when they're in that room? And then, of course, the planned physical activity is exercise. There are some relevant concepts to obesity related to addressing changes in body weight and physical activity. Moderate intensity exercise tends to burn more fat than high intensity exercise. The fuel that you use is more fat than carbohydrate. But high intensity exercisers tend to be the skinniest people. Both aerobic and strength training resistance exercise seem to be helpful in weight control, and important to tell people that it doesn't need to be going to the gym for an hour. Short bouts of exercise have been shown by Cheskin many years ago to be as effective for weight control as one long bout if you're keeping the total calories burned equal. There is an effect of physical activity not only on BMI, but on body fat distribution, and at least 2 large clinical trials have found a relationship there, in particular with visceral adiposity, and by and large, You're going to lose visceral adipose tissue when you do more physical activity. There are some demographic differences that have been found. The mechanism is not all that clear, but there do unfortunately seem to be some demographic differences in how this happens. Perhaps fortunately, the demographic group that is at one of the higher levels of cardiovascular risk, adult men, tend to lose more visceral adipose tissue when they become more physically active, studies show. So does exercising change body fat distribution in an obese person as well as in a normal weight person? Yes, but most studies have shown that the effect is pretty modest. Even training sedentary obese people to run marathons but not dieting at the same time causes a modest amount of fat loss. Men lose more than women, which women often complain about. Life's not fair in that respect. Older subjects in these kinds of studies, though, may actually, on average, gain weight, at least in one study that was done when they're more physically active. Lean tissue can increase while fat decreases. Why the changes are not more dramatic when you're training people to run marathons may be because of this compensation concept that I mentioned earlier. The exercise may be compensated by eating more at the same time and or more sedentary time. More physically active, maybe you plop down in the couch when you're not being physically active and turn on the TV. What about doing exercise while you're actually trying to lose weight if you're obese? Reviews do show a modest benefit, both in increasing fat loss and preserving fat-free mass. Men, again, tend to do better than women, higher metabolic rates. Weight maintenance probably is a more productive time to be physically active. Those who are physically active after losing weight, we call these the post-obese individuals, tend to do better when they are physically active, and this does positively impact weight maintenance. There's a large study called the National Weight Control Registry that shows that the good maintainers of weight loss spend about 400 calories a day being physically active, compared to the ones who are not good at maintaining their weight loss after a diet. And that's the equivalent of about 4 miles on a treadmill an hour. That would take if you're walking 4 miles an hour. Lots of health benefits of exercise. I won't bore this audience with the list that are both body composition and biochemical, and even, as you heard from Glenn Treisman a little while ago, mood-related and self-esteem and motivation-related. So prescribing exercise, we absolutely have to be conscious of the individual's propensities and interests, and they can change over time, but it's no use telling someone who is sedentary, start going to the gym, and here's your exercise plan, go to it, because it's not going to happen. And that is in part because of our society that you don't want to go to the gym if you're severely obese and look at a bunch of young people working out and flexing their muscles. It's not comfortable to do so. So home-based activities may be better, at least initially. But you have to find out what is getting in the way of that individual being more active, set goals, talk about barriers as well as support systems. Can you go do something with a friend or relative? Start logging what you're doing. You've probably heard of SMART goals. You want to give something specific. You don't want to just say, be more physically active. You want to say, you're going to walk for 10 minutes after dinner every evening when the weather is more than 30 degrees Celsius, Fahrenheit, and less than 90 degrees Fahrenheit outside. You're going to count how many steps you take or walk, how many blocks you walk. It's going to be action-oriented. You're going to do something. It's going to be realistic. We're not going to tell you to run marathons. And it's going to be timely. It'll make sense with your schedule. Anyway, an exercise prescription, ideally for weight control, will be both cardiorespiratory fitness, increasing the old aerobic types of activities, strength training and endurance, muscular fitness, as well as flexibility, which is the thing most often ignored. These are just some parameters for an exercise prescription. We do have to pay attention to heart rate maximums and setting goals based on what is reasonable for an obese person who has not been physically active before. Relative exertion is perhaps a better scale to use than heart rate for an obese individual, how much exertion they feel they are doing. Muscle fitness can start off with very light weights and progressively get to higher weights as tolerated, and flexibility can also be thrown in and should be thrown in. Special considerations in the obese is that you do want to be conscious of the risk of injury, muscle soreness. It's often more productive to focus on increasing the duration of an activity rather than trying to push it to higher and higher levels of intensity. So you walk for 5 minutes, then you walk for 10 minutes, as opposed to walk, then run, then gallop, Monitor closely for hyperthermia. That is an insulator, and potentially heat intolerance is an issue. Activities require a lot of balance and coordination. They'll be the best initially. Equipment sometimes needs to be modified or not even used. Capability for a more obese individual, and a setting, as I mentioned, that minimizes the unfortunate social stigma that we have out there. Common barriers are limited time, getting bored, fear of injuring oneself, and just lack of knowledge about physical activity and its benefits and rewards. At least half of people who start an exercise program will have quit within 6 months, and the owners of gyms will tell you that the numbers may be much higher even than that. You can enhance adherence with our recommendations when you keep in mind that it needs to be something that is reasonably convenient, economical. You have to be able to afford it, the gym membership, if you're going to be pushing gym memberships. You have to set realistic goals. You have to track them. It has to be structured within a schedule that works for the patient. And when you can get encouragement and support from family and friends, as well as us as healthcare providers, then you have the greatest chance of seeing good success over the long haul. That's all I wanted to say. A few resources that you're probably familiar with. Thank you.